what's the word now? Being
Recording is on.
present when we really needed you to talk to us on this subject. Thank you very much. So for the next hour, we're going to listen to Professor Ahmed on the topic that has been displayed. Motivational. I'm trying to remember the title. Motivational interviewing. It seems. So please, I think you just go on because it seems my microphone is still funny.
Okay, thank you very much, sir. Can you hear me? Good morning. TJ, if you don't mind, just discontinue yours. That's what I mean. You're the one showing now. Forget it.
Okay, I should show from my side.
No, you're showing now.
Okay.
You're the one showing. You've muted. I want you to not do anything, TJ. All right. Why TJ is doing this? Okay, good. Thank you very much. That's better. And I will say show slide. I will show myself. I will say this, and I should be good. And if I'm not good, well, too bad. Can you see my screen?
Yes, we are seeing your screen.
Okay. All right. Unfortunately,
we are seeing more than your presentation. That's deliberate.
what about now? Are you seeing my screen?
I mean, we're seeing the whole screen.
You're not seeing my presentation.
No, we're seeing your presentation and the rest of your presentation screen. So the slides lined up we're seeing. Is that what you want?
What about now?
We're still seeing everything. But it's better seeing everything than seeing nothing. So maybe we can go on. Just warning you that everything on your screen we are seeing.
I think he just has to put it in slideshow, that's all.
What about now?
Or presentation mode.
Yeah, presentation mode will solve the problem.
What are you doing? Yes. What are you seeing now?
We're seeing your whole screen, including the slides that are lined up 1, 2, 3, 4, 5, 6, 7. We're seeing your cursor moving around.
It's an inefficient program. I'm sorry.
All right. So I think it's better if you just present like that rather than.
Yeah, I think it's better. I think it's better than losing it. So just let's present like that. Just
okay.
Yes, I think it's best.
Well, good morning. We're going to be talking about motivation interview, and I really apologize for this. I try to make sure that we don't have this problem, but hey, that's the way it is. My goal this morning is to ensure that we're able to cover a lot of grounds. And part of the ground that I want us to cover, if I can get this to really work for me, is, oh gosh. All right. The learning objective is to look at the spirit of MI, motivation interviewing, various components of it, from us to there, and look at stages of change. And when your patient starts showing change, how to recognize them and how to sustain the change talk. Ideally, I would have liked to show this particular clip and other clips, but I'll probably find a way of sending this to you with the links so that you can also look at it. Most of them are, the particular links are freely available on YouTube and so on. Or otherwise, I'll download them and ensure that they come to you. Basically, what is motivational interviewing? Motivational interviewing is that, is a system of motivating individuals to engage in change. Is a form, is a way that is well recognized to help you induce change. It is not in the prerogative of psychiatry alone. In any, I mean, we're in the days of persuasion. How do you persuade your patient to engage in change? It's a change talk. That's what it is, really. And what is the key to change? That's something that we ask ourselves most of the time. What is the key to change? And the key to change reside with the individual rather than you. And this is well supported by research. The successful outcome in any form of transaction, and treatment is a transaction, right? Any form of transaction, focusing on treatment in particular, is how motivated the individual is. How motivated. We also know that if you're able to induce pre-treatment motivation, then you're likely to have an individual who attends and complete treatment and remain compliant throughout the stage of treatment. We also know that rating scale by counselors, psychotherapists, and so on and so forth, rating scale of motivation, and the prognosis in an individual is significantly affected if you're able to do this preparatory work. In my practice, I tend to look at motivational change at the initial stage, although I do more motivational work. However, REBT is then overlay when I get to the treatment phase, right? So generally, individuals who are well motivated tend to do better overall. This clip here is a clip that is there in the British Medical Journal. You can find it online. It's about an individual who came in. This man is fascinating, actually. He came in to see his doctor, and he was delayed. Unfortunately, that's what happened in medical practice. He was delayed. And then, I mean, he has hypertension, he has diabetes, quite a very ill person. And after he had been assessed, the physician then said, look, John, I need to talk about your weight. He had addressed, he had repeated his medication beyond. He said, but I need to talk about your weight because it's significant, etiological problem. I mean, causation of your hypertension. And the man got so upset. It's unfortunate I can't show this. The man got so upset in this interaction. And this guy did a very wonderful job, and it's better saying, did a wonderful job of redirecting him, but attended to his agenda because the guy was saying, you know what? I am a busy person. I came to see you. You delay me for 4 to 5 minutes, and now you're trying to criticize me for my weight. And the way he negotiated it is actually very helpful. I hope you look at it when I send the video. There's a lot of, before I go further, there's a lot of misconception about motivation. And probably we can do this exercise and you can answer it to yourself, or if you want to engage in, this is what I would normally do, ask participant to respond to this. But you can answer it to yourself. Until a person is motivated to change, there's not much we can do. True or false? True or false?
False.
Okay, why is that?
Because we could actually help the person to resolve the ambivalence that can now make them motivated to change.
Thank you very much. You are absolutely correct. This used to be the sort of thing that happened, particularly in my subspecialty, forensic. Oh, this individual is not ready to take treatment, therefore don't come in. In addiction, it happens as well. And if you look at the origin, a motivational interview is more has been used a lot in addiction. So what until the individual show an element of change, either by behavior or calling or so, it is false. We all know. Because I don't care what motivates you to come for treatment, either external, internal, or your force or whatever. Everybody has ambivalence. I had ambivalence accepting this presentation. If I had known that my slide will not work, I'll probably lean towards not coming. But TJ was so persuasive. He used a lot of motivational techniques and said, hey, come on, you can do it. And I came over, right? So ambivalence is part of our day-to-day interaction. And because of that ambivalence, you will see that individuals, at the time you're catching them, they may not be displaying motivation. Therefore, it is false to say until then before you can take them. It usually takes a significant crisis to motivate a person to change. What do you think about that? It usually takes significant. Is that false? True or false? Obviously, it's false. The answer is there,
It's
right?
false.
It's
Yes.
false. Why is that?
There are many reasons why people may want to change. It's not only significant negative events.
Yeah,
So,
yeah, yeah. We do know that distress, uh, crises, or so, there may be catalyst to change. It's an opportunity to change. But unfortunately, it does not mean that it has to happen. Motivation is influenced by human connection. Motivation is influenced by human connection. Is it true or false?
that is true
Okay, why is that?
because usually, in fact, that actually is the hallmark of motivational interviewing, to say that sometimes we get people, when you listen to people, they aspire to greater things by virtue of the interactions you have with them and all that.
Absolutely. Yeah, because if I'm not connected with you, it's a complete waste of time to want to do anything. If I'm not connected with you, and I don't, if you're unlikable or you, then it will be difficult. And therefore, it is very important that you bear that in mind, that you want to ensure that you are connected with your patient in order to motivate change. So I have to like you. Otherwise, I'm battling within my brain with resistance. I don't know if I want to really, I'm just listening here. I have different agenda. So you are absolutely correct. The connection is there. So you better spend a lot of time trying to connect with your patient. Resistance to change arises from deep-seated defense mechanism. What do you think?
I think
Resistant to
that's true.
change. Yeah. So basically, we know that individuals who it may not manifest to you, and it's better that you bear that in mind that actually I may not know why this guy is protesting because it's deeply seated denial and all the rest of them is a problem. Those are some of the basic things. People choose whether or not they want to change or they will change. Absolutely. Change is something that belongs to the individual at the end of the day. It doesn't matter. It doesn't matter what your pastor, rabbi, anybody tells you. The change really reside with you. And if I'm not ready to change, it doesn't matter. You can lash me. You can do whatever you want to do as we try to beat out the devil. But definitely change reside with the individual. Readiness to change involve a balance of pros and cons. And this balance, CBA, can be done subconsciously. It doesn't have to be conscious. An individual does CBA, whether they're doing it technically or they're doing it subconsciously before they engage in the process of change. So we need to bear that in mind. So you better be able to give them enough evidence that we get them to say, I'm leaning towards the benefit of change. And creating motivation for change usually requires confrontation. What do you think about that? And we're going to talk some more about confrontation. What do you think?
That's false. So that will definitely lead to the opposite of what you are looking for.
Why is that?
Because people are defensive. People want to look good. So if you are confrontational, then you are not likely going to get their cooperation and the connection that we talked about earlier.
I like that word defensive. It's now a defense of the ego. It becomes a battle of ego, period. It's no longer about the subject. It's you wanting to attack my ego. Whether you like it or not, I want to tell you that, yes, I can defend that ego. And that becomes the subject matter rather than what you're trying to do. Denial is not a client's problem. It is a therapist skills problem. Uh-huh. What do you think? Denial is not a client's problem, it's a therapist's problem. What do you think?
Well, I think it's a therapist's problem.
I
It's a
think so.
therapist's problem.
Therapist problem.
Why is
Yes.
that, sir? Prof, why is that?
Well, he better steps up his skills.
Exactly. Because the person people will always have denial. But it's the therapist that should know how to navigate that, not the patient.
Uh-huh. In motivational
So
interviewing, yeah, in motivational interviewing, sorry, Prof, in motivational interviewing, denial is seen as a resistance. And it is the therapist's problem. I don't want to call it problem. It is the therapist's responsiveness. Responsivity is the property of the carer. That is from either the individual or the institution. So it's your problem, as Professor Kingsley said, to negotiate the resistance. If you don't know how to get out of the resistance, that's your problem. You need to upscale your skills. So those are some of the, we have the basics now. So we'll finish this talk on motivation and interviewing. We've answered all the questions because I've covered everything that I wanted to talk about in those about 8 or 9 questions. So a client's motivation is greatly influenced by the therapist, right? Client's motivation, retention, outcome vary with the particular counselor. So some people are likable, some people are not likable. The style that you use, your personality, what you show, whether you're confrontational or whether you're empathic and so on. And you'll be surprised to hear a rational emotive behavior therapist talking because I'm very active and directive, and my personality, and even in my therapy style, that I'm saying confrontation doesn't work. Yes, you may want to challenge your rationality to leap into that, but you can do it in a way that you're not confrontational. And it's an art that you better develop. Counselor, we know the counselors with the biggest, you are the biggest determinant. You talk about therapeutic alliance that you've talked about, I'm sure, in these sessions. That ability to form a relationship and a bond, therapeutic bond with the patient to move them to change is one of the biggest determinant of your role. What then is readiness to change? And what is the readiness? What are you talking about when you talk about readiness to change? Most of the time, we ask ourselves, why is John why is it John ready or not motivated to change? The question we should be asking ourselves, what is this person motivated to do? It's not why are you not motivated to change? It is what are you motivated to do? Because if I know what you're motivated to do, then I can walk through what you're motivated to do to get to the change. The pitfall, as you know, is that you assume that the person, that you know the person more than the person. I'll give you an example. Most of my patients, as a forensic psychiatrist, most of my patients do not see themselves as having problem. The antisocial personality person, because everything is egocentric to him, he doesn't see himself as having problem, right? So you're saying, well, but whether you like it or not, the guy is motivated not to go back to jail. He doesn't see his behavior, the fact that he's bashed his wife, the fact that he was drunk. No, he doesn't see that as a problem. But certainly, the guy is motivated to remain in the community, at least to go and rob the next bank, right? My job then is to work with him to see how I can go through his motivation to remain in the community to get him to start being motivated to stop using drugs, and so on and so forth. So it's very important. There's this element that we tend to talk about is called the writing reflex. Writing reflex. And writing reflex essentially is that I believe narcissistically, as a physician, as a counselor, believe that I know what is right. And subconsciously, I will be motivating you to come along with me to achieve what I define as right. It is instinctual. So if you continue to use writing reflex, and you've got to be aware of this, then you discover that your ability to induce change will be severely affected. And the kind of thing is, why don't you want to change? Is a writing reflex question. It is instinctual. Why doesn't Joe want to change? You do your word round, you're discussing with your colleague. Why doesn't he want to change? Why won't you try? Okay, then, how about this? What makes you think you're not at risk? These are all writing reflex questions. How could you tell me you don't have a problem? We couch it in the language, the guy is in sightless and whatever, and then that is the way we relate to the individual. So it can be subtle. So writing reflex is something that we need to be very, very much aware, and it is not in keeping with motivational interviewing. Other things is you arguing that the patient has a problem and needs to change, and emphasizing the symptoms or diagnosis is not motivational interviewing. We all know that when you're defining insight, you go onto about 5 levels or whatever. Do you accept the symptom? Do you know this? Do you accept that this symptom is part of is part of a mental illness? You think that this symptom is part of a mental illness, has biological basis? Do you know that if you take medication and psychotherapy, you're likely to get better? And finally, if you don't do any of these, you're not likely to get better. Yes, you talk about all those things nicely, but really, it's from your own frame of reference. It is not motivational interviewing to offer direct advice or prescribe solution or coping strategy without actively encouraging the patient to make his choice. So even if you're going to say, well, I want you to take this medication, I'd like you to make this medication, and if you don't want to take it, these are the consequences, and so on, after you've done the work to engage them, understanding what they are motivated for, without doing that kind of background job work, your prescription is not motivational. No wonder your patient will probably not be compliant. It is not motivational interviewing to use authoritative or expert stance and leave your patient in a passive role. Yes, doctor. All right? Yes, doctor. Whatever you say, doctor. And it is culturally different the way you talk to this patient. And that's one of the things that when it is very, very noticeable. I mean, it depends on where you're working. But most of the time, if you're looking at motivational interviewing and you really want individuals who accept treatment because they internally want to do it, it is not by you saying, I'm the physician, I have all the answers. Rather, I want to talk to you. I want to talk with you, and I want you to talk to me and talk with me. Okay? It is not motivational interviewing to do most of the talking. And in fact, a unidirectional information system where you are the library of information and you're pouring it out may not foster motivational interviewing. That's why Socratic methods tend to be more effective. Asking the question, getting the answer, getting them to ask you the question, and building a relationship. It is not motivational interviewing for you to identify. This is not the period that you'll be identifying cognitive distortion, irrational beliefs, and you'll be pointing it out to me. And you'll be surprised again that, come on, AG, I work as a cognitive therapist, but this is not the time. In one of our programs, VSTOP, Virtual Intensive Treatment for Outpatient program, what we tend to do is that we spend 3 months focusing on other aspects, motivational interviewing per se. And it is the second 3 months that we actually go into relationship realities and cognitive restructuring. So when you are in the motivational interviewing stance, you don't want to point out my maladaptive thinking. Motivational interviewing allows the client to determine the content and direction of counseling. It is what this means is that although you're respectful of the patient taking charge, but then your questioning is directed at motivating them to reassess themselves, to reassess their commitment to change. It is not motivational interviewing to be punitive or to be coercive in whatever form of it, whether it's actively coercive or I'm canceling your clinic because you are late today, although you have the time to work with the patient. That will not be motivational interview. One of the other things they say is that when you engage in motivational interviewing, the idea you take one side, I take another. When you strongly argue one side, the ambivalence on the other side may increase. And we've said that ambivalence is a normal human phenomenon in whatever we do. The stronger the argument, the less likely for any change to occur. So I argue this way, you argue that way, the less likely for us to come to a change. Rather, you may want to invite for further exploration. Unfortunately, again, we'll not be able to watch this video, but essentially this is showing you the common human reaction to writing reflex. Emotion that is most common in writing reflexes will be anger, followed by behavior manifestation of it in the form of agitation, opposition, discounting what you've said, becoming defensive, justifying my position, not being understood, not being heard, and you procrastinate. And when all this occurs, what you tend to find is that individuals become afraid of you rather than respect your opinion. They feel helpless, and whatever information you give becomes overwhelming. They're ashamed, they're trapped, they're discouraged, and disengage. They may avoid you. And even if they come forced by other psychosocial situation, they may be uncomfortable in your presence. Their resistance increase, and they will probably be struggling with that rather than genuinely engaging in changes. However, when you address this writing reflex, you are aware of it in yourself, the opposite happens. I feel safe, I feel empowered, I feel hopeful. I feel that I'm being listened to. I really want to come back. I look forward to going to see my doctor or my counselor because I know it's a safe place. That is the story. That is the narration that you want to create. So, most of the time, we talk about the roles that we all play. You don't have to make change happen. You don't have to make change happen. You would like change to happen, but you don't have to make it happen. And in fact, you can make anybody change as a therapist, as a counselor, as a physician. You can make them change. And that the extreme case of it is what tends to happen when you have an individual who is psychotic and is taken to a place where you find that we subconsciously engage in a sort of punitive as a negative reinforcement. Let them be in seclusion until they're ready to change. We don't engage in discussion with our patient on how to get him out of seclusion, but we say, well, he's not ready to come out yet. And that's a reminiscence of what they did when they chained people down. So sometimes you get to know the symbolic meaning of some of this behavior. The other thing is that you don't have to come up with all the answers. Yes, you do have the knowledge. Yes, you do, but you don't have to come up with all the answers. You probably don't even know what is the best for that particular person at that particular time. Always remember that you want to avoid wrestling with your patient, but you want to have a nice soiree. You want to dance with them. It's not a wrestling match, it's a dance. And that gives them more comfort. What is ambivalence? Ambivalence is I want to change, but I don't want to. Very few decisions in life, including even the one we're not aware of, very few decisions in life are 100%. This is exactly what I want. Ambivalence is normal. And if it is normal, it is part of the change process. So, bearing that in mind and trying to find a way to attend to ambivalence. This is an exercise that we do normally when I do full motivational interviewing training. You get people to, we skipped it, but essentially is actually find a partner. You find it in the slide. You can try it with your students, with your residents. You can try it. You go in partners, decide on something that you want to do or something they want to change. The details are there. Why did you do it? And then explain it and change the role. It's very straightforward. So, what then is motivational interviewing? Having cleared all those in writing reflects ambivalence and so on, addressing our own narcissistic defense, ego defense, even among within us, not to talk about the interaction with the patient. It is a semi-directive, client-centered counseling style, and the goal is to enhance motivation for change. And you want to assist your patient through clear communication to resolve their ambivalence, which is a normal behavior. The goal of motivational interviewing is to create and or amplify discrepancy between the patient's behavior, an individual's behavior, and the broad goal. The broader goal other than the immediate goal. If you have this clear definition in mind, it will remove the resistance that tend to be within us as therapists. You want to create that dissonance between my behavior and what I said I would like to change. My patient going to, they discharge into the community, they come back, they relapse, they come back, and so on and so forth. I want to stay in the community. I want to be with my family or whatever it is. That is the broader goal. Compliance with medication. Because I do not even believe that I have schizophrenia, it's not the patient's responsibility. It's not his goal. It's not what he wants to change because he's insightless. So better focus to that broader goal and then help the patient to track it down. Create a cognitive dissonance between where one is now. Where are you now to where you want to be? That's your job. If you look at motivational interviewing, if you look at this idea, what do we mean when we say it is semi-directive? Compare it with Rogerian approach or any of those, you will find that why you allow patient to determine the content and direction of your interaction. In motivational interviewing, you follow systematically and get the patient to move towards change. And this is very important. You're not just allowing the individual to go ahead to say that this is the way I choose to live my life. No, I respectfully agree with you, but let us explore how you want to get to where you really want to be. A non-directive or Rogerian approach, you will explore the patient's conflict and emotion without specific goal to change. You let change evolve from them. In motivational interviewing, because of the directiveness that is with specific goal in mind, your questioning is to evoke and amplify discrepancy. You deliberately want to create an anxiety, if you want to put it that way, that will help the patient, galvanize the patient towards change. In non-directive Rogerian approach, you will do empathic reflection. I can imagine. Non-congenial, empathic. But in motivational interviewing, in fact, you will ignore certain things, but you will be selectively directing your patient towards motivation. You allow your patient to talk nonstop and wait and provide feedback at the end of the day or your interpretation. No. A motivational interview with your active listening and rephrasing of what the patient is telling you, you offer feedback. You will offer a manifestation of the discrepancy between what they are saying and what they told you their goals are. In one of the videos that we didn't see here, that gentleman that I told you before, he said that, well, I know I'm overweight and I know I should do exercise and so on and so forth, but I'm too busy. And that seems to be, so I can't do it. And by the way, that's none of your business. So you can see hostility even directed at the physician. If you're looking at Rogeria, you'll probably be seeking and say, well, what does it mean? Exploring that transference towards you or whatever. In motivational interviewing, that will be a distraction to your goal. You're looking for nuggets that you put together to become goal bar towards the change. There are two phases of motivational interviewing. The first phase is building the motivation to change yourself, and the second one is sustaining commitment to change. You got to bear that in mind, and you got to know where you are. And unfortunately, in motivational interviewing, you may find that individuals who have substance use, for instance, or if they have co-occurring disorder, mental illness, substance use, you may discover you're in phase one for psychosis or whatever it is, and you're in a different phase two, for substance use itself. So it's a dance between where you are. And even for substance use, polysubstance use individual, you may discover that you're in phase one for cigarette smoking, but you're in phase two for abstinence from alcohol. So bear that in mind and don't assume. So when you're talking about change, we're all familiar with the Prochaska, de Clementi stages of change, right? We don't have to explain that. Yeah, we're familiar with it. There are appropriate motivational strategies that are associated with each of this. So we just try to look at it. In pre-contemplative stage, the patient is not considering changes or willing to change, is unable to change, is not even thinking about change. What does a motivational interviewing clinician would do in this stage is to establish rapport, ask permission, focus on building trust. You want to get that patient to trust you, to be able to contain all the emotional outburst and the negative transference. You'll be able to contain it. Raise doubt and concern in the client about the problematic pattern of behavior. Express your concern and keep the door open. So going back to my first example, what the physician did for that overweight individual was that, okay, fine, Mr. John, I understand you're a busy person, reflective. I understand you're a busy person and you don't have the time, but you do realize that your weight is a problem. And I understand you're very upset this morning because I've kept you waiting. Why don't we arrange it that you come in a week? But I want you to think about your weight. And then he said, and I'm going to make it easy for you. Why don't you come at 8:30 in the morning rather than come later in the afternoon when I'll have more patience? That is the sort of thing that is building that trust. What about the patient that acknowledges their problem? They're, they're thinking about change in the contemplative stage, is to agree that there's ambivalence and it's a normal thing. Help the patient to tip their decision towards change. Elicit and summarize self-motivation statement that might have come during your interaction. Elicit ideas regarding the patient perceived efficacy, because they may say, I don't think I can do it, and so on. What will it take? Where will I get the time? These are the sort of focus in contemplative stage. What about when the patient is preparing? The patient say, I want to do it, is committed and wants to make a change in the near future, not ready now, but in the near future, I'll do it. They're searching, which hospital should I go? Should I go to Aro? Should I go to Yaba? Maybe Enugu will be the best place to take treatment for my addiction. Explore the treatment expenses and the patient's role or the client's role. Clarify their goal. Negotiate a change and the treatment plan. Consider and lower barriers for them and assist in whatever way you can and get support for them. What about the patient that is already taking action? Basically, what you're looking at in this stage is to take the steps. They already is to engage the patient in the treatment and reinforce the importance of retaining that change. Whatever difficulty they have, you want to also help them to resolve it. Help them to identify high-risk situation and what to do. What about when the patient has successfully done what they needed to do in the initial stage of treatment? It's now moving to maintenance, and you're going to be looking at how do I support the lifestyle changes? What are the kind of things to do? Affirming the patient's resolve and self-efficacy and how they've gotten there becomes very important. Helping the patient to practice and use new coping strategies and ensuring that you have, crisis management or fire escapes should there be lapses in the future. Review the long-term goal will be one of the things. And if there's a reoccurrence, you go back through the cycle again without being judgmental and reconsider the positive and the changes, and you may go to what you did in the initial stage when they were contemplating, depending on how. The three critical components of motivation for motivation is this readiness and being able to determine the ability and so on. So you look at, are you willing to change? Are you able to change? And are you ready to change? The importance of change is what you're focusing on, and willingness, desire to change, wants, and the will to change. What about the confidence? Do they feel, do they believe that they have it in themselves to change? And it will be our responsibility to ensure that we sort of highlight those abilities and the strength they have. And the readiness deals more with the ambivalence. At that time, I'm willing to, but I'm not ready to. Not now, maybe next time. The 5 principles in terms of what you do exactly is represented by adherence, develop discrepancy. I've said that before. Express empathy. Research indicate that if you're the more empathic you are, the more you're likely to carry your patient along. A means you avoid confrontation, because the more you confront, we've talked about it, it creates this ego conflict, and then you're stuck. You're not able to move your patient along. When a patient is resistant, there's this element of you rolling with resistance. And we know that providers who are able to reduce resistance are likely to have the patient retain them long enough to make progress. If you engage in any behavior that increases resistance, you know what will happen. So remember the source of that. Support efficacy. And this is very important. And this is where a person's belief in the possibility of change, and whatever element that you see, you're bringing it to light for the patient to see, becomes a very important part. You're not indulging them, you're moving them along. Resistance, we're all aware of resistance in all forms of psychotherapy or human reaction. How do we deal with resistance in motivational interviewing? Of course, it manifests verbal, non-verbal, expected, and it's normal. It is a function of interpersonal relationship. Continual resistance predictive of reduced change. So you better be responsive to the resistance of your patient. Don't let it surprise you. It will come. And getting resistant means I need to change my style as a therapist. There's something here that I'm not doing if the resistance persists. And don't be afraid to say that. Don't be afraid to own it to yourself and say, AG, what is it that I'm doing differently? How am I doing certain things here? How can I change it? It's not to put the blame on your client. And these are the forms of ways when patients start arguing with you, they're not following they're challenging your opinion, they're not following what you've said, and they may be frank hostility. Either talking over you, cutting you off during sessions, ignoring what you say, non-response to your questions, non-answer to your questions, sidetracking you, looking away, and so on. Denial It may manifest, resistance may manifest as denial, the blame, disagreeing, excusing, reluctance to participate, minimizing what you've said, even the gains they've made, being pessimistic, unwilling to change, and claiming immunity. Whatever it is, you say something, you say, what else? Have you finished? Wanting to break the time. So those are the kind of things. Many older approaches to behavior change rely on the counselor begging or even intimidating, persuading the patient. These approaches often elicit reactions and reduces the chances that a resistant client would consider changing. When you engage in this form of persuasion. And that's why we talk about in motivational interviewing that active nature of it and that active aspect of it, and the active is directed towards. So if you see any distraction, you don't want to follow, you want to bring them back. So you can be assertive in motivational interviewing to some extent while respecting the patient. I talk about dancing and wrestling. Many proponents of MI use the metaphor of dancing with the client to illustrate a method that gently move your patient around the ambivalence. That's what it means. I can understand how difficult it is for you to make the change, to talk about this change, bearing the sort of things that you may lose and the time investment. But shall we look at these one by one? Those are the dance steps. I had mentioned this before, but I'll say it again. The picture on the right is the sort of thing that, imagine that as the mind of your patient, so many lights and so on and so forth. You don't even know where you're going. But you may get a hook. And the hook that we're talking about here is what exactly is of importance to you. What is of value to you as a person? Find that hook, find that light in these array of lights and so on, and get hooked onto that. And you're not doing it just for one session, two sessions. It may be all through the journey. The therapeutic journey, you will be referring to it and going back and forth. Very important. So what are the areas? You see that light that I was showing you here? They represent all this. Family, parenting, love, marriage, friends, social connection, work, career, education, recreation, spirituality, citizenship, politics, whatever it is. Find something. Try to make a connection between that thing, the hook, and the goal for the patient. So we're going to deal with any questions so far. That's all I've got to say. We just have some case demonstration here that we hopefully will be able to have at least one discussion, review one case. Any question at this stage? Is it crystal clear or as clear as mud? Hello?
We are with you, sir.
Yeah, I'm just pausing a bit and saying that are there questions about motivation interviewing before we go into an example here?
Um, uh, I, Usually, at times we finish and people do ask about. If people have question, I'm sure they can raise up their hand and talk now. Number 39, do you want to ask a question?
That's a funny name, number 39.
I of course try to, so if I may ask this, I try to look at the cultural angle to motivation interviewing. I look at in our cultural context where it is customary for the younger to always respect the elderly, and the elderly usually use confrontation as a style to get the younger ones to do things. And this style do work at times in some clinical scenario. A younger person meeting an elderly therapist, a clinician, the younger person automatically is primed to take uh, the lead, being guided through by the clinician, than if it's an elderly to a younger person. So I'm trying to look at our cultural context where, if that's the scenario, then the idea of trying to uh, follow the spirit of MI might not fully follow that rule. But if you look at it reverse, that the therapist is younger and the patient is elderly, or the clinician is younger, the patient is elderly, then maybe perhaps this might help the clinician to be able to get the needed uh, interaction, engagement to bring about the value that the patient knows that he needs to embrace so that he can benefit from such interaction. I don't know if I'm able to put my thoughts well enough to bring the issue up. Thank you, sir.
Thank you very much. Actually, you're very eloquent about it. I think the the question here is: are you using fear to coerce change, or the change is coming as a result of respect? So, there's no doubt about it. If you're respected, whatever change that comes is more likely to be sustained. If you were to use coercion or confrontation, or intimidation, whatever change you instill is induced by fear. And once the fear is gone, the change may fizzle away. The second thing is the fear may not be sustained enough, and if you push too hard, rebellion can start. And then you find that the individual will start showing evidence of resistance. And that's that's the problem. In motivational interviewing, the client is not a passive recipient. That person is an active participant in creating the change. That is the difference. Of course, I'm not discounting what my rabbi would tell me, what my imam or my pastor would tell me, advice, because I defer to them. That's different. But if you're doing motivational interviewing, and it can work even within our culture, if you're doing motivation interviewing, I think you're probably going to, we're saying be respectful of the patient and the patient we reciprocate rather than wanting to force them to do things now. It has to happen now. I don't know if I'm making myself clear. So it's a different dynamics from I am telling you as an authoritative figure. I'm saying let us examine things. I understand what your goal in life is. I've found a hook. I've found what is it that you really want to change, or what is it that is most important to you. And how can I go from your current behavior and the goal or something that is important to you? There's a delta, there's a discrepancy. How can I help you get there? And how can we work together? It's different from you do this, you did, be a good boy, do this, or whatever. That's persuasion, that's advice, that's not motivational interviewing. Got it?
Yes, I got it. I'm just trying to look at the various style that is we'll find in our clinics, in our accountants. So
Yeah.
of course, motivation interview provide one of the best option. But in some
Mhm.
few cases, the coercion do work for some people too. So I don't know what other transferential
Yes,
issues.
yeah. Maybe I should comment. Maybe I should comment. When if question works, then it's fine. It is not motivational interview you are doing.
Yeah,
I think we
yeah,
just
that's true.
Yes,
yeah, that's it.
yes, sir.
So if there's such an obvious or difficult power difference between the two people, I don't even think motivation interview is possible, because once there's that power gradient, it's going to, once the therapist is not able to be at the same level for a dance, then it's going to be a teacher and a student kind of thing. The relationship between the therapist or someone doing motivational interview and the client is not the same as an instructor or
Yeah,
as a teacher.
yeah, you're absolutely correct. So that would be different. That would not be motivational interviewing.
Yeah, thank you, sir. Sir,
And maybe I should just add that
Mhm.
in maybe I should just add, in a psychodynamic situation, the people, especially in psychoanalysis, the therapist is expected to do some self-analysis.
Mhm.
So
Mhm.
maybe we should have it in mind that in getting yourself preparing to do motivation interview, you need to get yourself prepared to it. Part of the training should be getting you to be able to level with your client or patient wherever he is. Once that power structure exists, it's the person is going to obey your instructions, but it's not going along with you. He
Yes,
can
yes.
listen to you. Yeah, that's it. Yes.
Yeah, you're absolutely correct. And and that such motivation, I mean, such compliance is known to be very weak according to motivational interview because it's not intrinsic. They will say, okay, sure, you told me to do it because that's it, or what they may say, you coerce them or whatever. But in motivational interview, you are trying to get the individual, you are trying to get them to intrinsically engage in the change process. You're not trying to force them, you're trying to make it innate to them. And that's your job in motivational interviewing. And it's not incompatible with other intervention because once you've done that, you can come and do your cognitive restructuring. You can do whatever you want to do, but I want to get you, I want to see how I can help you to embark in the change journey. That is the sort of thing that we're talking about in the way that it becomes your own, not because I'm telling you.
thank you, sir.
Um,
It's like Dr. Professor
so let me just
want to say something. Okay.
yes. I want to say that for me, the whole essence of the motivational interviewing is for us to be able to get the best out of that therapeutic relationship. So,
Mhm.
like Dr. Tajuddin said now, we are used to that paternalistic way of doing things, which we also know doesn't work, because even if we say in our culture we don't argue with elders and everything, people leave the house and go and do whatever they have always done.
Yeah. Yeah. Hello? Prof is gone.
Well, still, the rest of us are here. He might be gone.
So,
I'm just wondering, uh, 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 Prof, if you're able to play your videos on your own system, we can also see it.
No, I we tried that. That's the problem. We tried it and I couldn't get
Okay, did it work? Okay, not
into.
through the link, not through the your presentation.
Hmm.
That
Want for yourself
ordinarily,
and all that.
Can you hear anything?
Hello?
yeah, it's
Hello?
playing. But,
Can you hear me?
Oh,
yeah,
Sorry.
we're hearing you.
No, can you hear my?
Okay, no, we're not here. We're just seeing the. We're not hearing.
Let me see if I can get
You
to
want
the
to increase
views.
the
okay.
volume?
Hello?
Yeah, yeah. Prof, continue.
Hello?
I'll continue, Professor Konoda.
Prof, please continue. It's gone again.
He's gone again. But somebody else is also raising up hand. Dr.
Please.
Olaitan, please kindly make your contribution to your question.
Okay, so can you hear me?
Okay,
Yes, we can,
Konoda is
Prof.
back. Yes.
All right, so I was saying that, can you hear me now?
Yes.
So I was saying that irrespective of the power differential, it is the role of the therapist to create a partnership
Yeah.
such that the patient will be able to be comfortable bringing out the things that are important to him that he can work on. And then the therapist is also expected to have a spirit of acceptance, you know.
Hmm.
I always say that acceptance is not the
I think there's something in Jaws that doesn't allow them to speak.
that yes. So have that create that spirit. That's what makes people to be able to open up, not the one that will make them look as if they are so bad that they are disgusted at them and all that. And then when that happens now, then we go on to the process of empathy and compassion, to try and put yourself in their shoes, and then compassion to try and solve the problem that they have. And then finally, they talk about evocation, helping them to bring out the solution from within them, because
Hmm.
everybody seems to be an expert in themselves and all that. So I believe that if
Wow. Prof is gone again.
Yes. Maybe before you come back, there is also Dr. Saliu. He raised up his hand. If you
No, 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 no. But before we go to another person, I think what Prof is saying is basically the that if we are calling it motivational interview, I think we should stick to it because
yes,
it's possible. Even if you are a teacher and your student is having difficulty in learning something, you can break it down, do all sort of things, and the student finally agrees with you that you've solved the problem and things like that. Meanwhile, he's not able to follow you. So if we are changing, I mean, motivation interview is not the only method of interviewing.
Yeah.
Pastors, other teachers, other people use other methods, and eventually the person complies. I think that's the word. We can use big stick or respect or damper structure, and the person complies with what you want. That's not really what we are hoping to,
Yeah.
because that power dynamics would make cause compliance, and it's not really what is required.
Yeah. Absolutely. And that's not the essence. That's not motivational interviewing. And you're right. There's so many methods that you get people to comply. There's no doubt about it. But in motivation interviewing specifically, those are the sort of things. Maybe I should just summarize with this, end with this sort of the steps
Uh,
in motivational interviewing.
Sir, sorry, sir.
Yeah.
There's still two more people who raise up their hand. If you want them to,
Oh, okay. Sorry.
Dr. Saliu, Dr. Lighton Saliu. Are you
Okay.
okay?
Thank you, sir. Am I audible, sir?
Yes.
All right. Good day, everyone. I just want to thank Professor AG for the beautiful lecture on the motivational interview this morning. I just want to share my experience, I think, as a yesterday on a patient. I
Mm.
feel that it's more relevant uh, at this particular lecture. I was called to see a patient yesterday who on a medical ward who came in because of the wound, bilateral leg thigh ulcers. And that was the basis why the patient presented in the hospital. I realized that as at the time when the medical team and possibly the surgeons were trying to review the patient, I think there were a lot of confrontational in terms of what they thought could be responsible for the wound. And majorly, this patient is an injection user, uses opioid pentazocine to be specifically. And this has been on, according to the family, for close to 16 years now. Again, the patient had always denied and tried to hide these habits for a very long time. He lives alone, he has separated from the family. He's also a pharmacist, to put it in a context, and 70-year-old man.
Hmm.
So, but in all of this, the a lot of confrontation coming before, prior to the invitation of a psychiatrist to come into the case. So I got in there, went in into a discussions with the patient, even when I tried to also excuse all the other people that were there. And in my 1 hour sessions with him, been trying to talk around the whole issues centered around motivational interviewing. I realized that even though when I tried to avoid being confrontational as much as possible, the patients holds on to the fact that those wounds arises from hot water that poured, accidentally poured into his thighs at a time, which
Yeah.
was some few months back. So he never agreed at any point in time that he uses pentazocine or he uses any injections or whatever form. And again, at that time, the wound is already discharging and he's so much concerned. The patient needs help at that particular time. He acknowledged the fact that he needed help. But again, how this wound arises, patient did not agree that this is as a result of injections or whatsoever. In fact, he said he never used any injections. He doesn't even sell any injections of salt, any opioid in his shops and all that. And he had never used it at a time that he denied any issue of those use. So, but again, I was trying to being in a way, try to just do a general counseling for the patient and to also let him see the need that we are trying to assess help for the wound. But again, we must also look at what led to this wound. So that even while we are trying to see the solutions to this wound, again, we must be able to see what led to this wound so that we can see how we can come in and intervene in that way without necessarily passing any judgment whatsoever. But again, patient also acknowledged how comfortable he was discussing with me. But throughout the whole discussions, he still, even when a lot of therapeutic relationship was built and some level of trust, but again, he never owned up to the fact that this is an injections and all that. Again, my worry is also that this patient is now under a confined environment in the environment. Depending on the level of the user and according to the relative, he may also likely go into a serious withdrawal. So within a couple of days, or even within even that same day, if he didn't have any access to opioid as is usually using it. So how do we go about it? I know one-off session is not what we expect that kind of a patient to just own up, but I also want to believe that there may be other method, practical method that may be useful in the future engagement with this patient, if at all. So, and that's why I put it to Professor AG Ahmed, if he could also
Thank you very much. Uh, I think you you
more than
you
subsequent session. Thank you once again for the beautiful lecture.
thank you. I think you touch on something very important. Prioritizing what goal and at what time. What you're trying to do here, in your case, I mean, with regards to that person, there's an acute. The patient is in acute phase. He has an infected wound, and of course, he has a background chronic substance use. Assuming that's the case, you have engaged with him to address this, what he wanted to work on at that time. You're saying, you know what? At this stage, your wound is important. Let us see how we can work about that. And you're developing rapport with him. Kudos to you. When you come back, because change is a process, when you come back, you build a rapport with him. You build a relationship that is predicated on respect for his desire at that time. So it will certainly be easier, that's my assumption, when you come back to pick the change talk and moving towards changing the chronic habit. You've got this infection, you're now having withdrawal symptoms. What could be the reason? Your goal, your broader goal, hook, is for you to be well. You were worried when you had that infection. You were obviously sick. What we're seeing, your behavior now, this is a withdrawal. This is an indication. I mean, you're a professional. You know that it's withdrawing. When you come back at the next stage, I think you bring all those together. And I'm sure with the kind of rapport you've developed, it will probably be easier than what the surgeons are doing, confronting him. And that's the essence. Does that make sense? You've started, you didn't say he must confess at this time that he's a drug user. You say, no, leave it alone. We'll talk about it later. That's part of it. Okay?
Thank you,
I
sir.
think that's
I
what
still one more
yeah.
person, sir. If you can go ahead. Dr. Ubong Dofia, kindly go ahead. Dr.
Okay,
Ubong.
thank you, Prof, for your presentation. I really enjoyed it. My question, we are in Nigeria. Nigeria is a resource poor country, so we have very few doctors, psychiatrists to patients. And with the look of MI is not a short process. It might take an hour plus. Now, talking about even training people on I think principles like empathy, compassion, you're basically asking a person to change who they are. So, you're basically asking the therapist or the person doing the MI to change who his default personality, things like compassion, empathy, and the rest are personality traits. So you're
Yeah.
asking them to do this, and no matter how things are, at a point the person's true person would come out into the mix, and it might make the MI process a bit difficult. So my question is: it not? Is it possible to have a system where we have like a manualized form of MI that doesn't allow the person to express their true personality, such that they are in, like, once they are engaged in this process, they cannot be themselves, because there's a guide that allows them not to be argumentative. There's a guide that allows them not to be confrontational. So that's my question.
Great question. Thank you, Doc. There's no doubt that every doctor is a human being, although AI will take over very soon, and there'll be no more doctors. And we all have our quirks, we all have our traits, and so on, and it comes up. And I don't think it's manual that will change you or change me. I think it's going to be having the knowledge and having the practical skill to use it. I see psychotherapy, any form of psychotherapy or any form of patient interaction as an act. That's an act. And every act, you learn and master it. And that's the significance of supervision. Empathy can be learned. So you go from declarative knowledge. Today we've had declarative knowledge. You've had declarative knowledge before. This is the didactic lecture, watching video, blah, 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 blah. Then you go to practical knowledge, which is actually doing it. And that's the essence of supervision. You are absolutely correct. That's why most of the time you go and do all this training in psychotherapy. If you're not practicing it, you lose it. And it doesn't matter, even if I gave you manual, right? You're not going to carry manual when you're sitting down there. You've got to practice reflective listening, which is an element of MI. You've got to practice this. Use your Socratic questioning. Could you tell me more? You've got to practice all those skills that we learn that is respectful of the patient. So, will manual help? I'm not going to have manual when I'm doing it. Will supervision help? Will case discussion with my colleagues help? Absolutely. Okay?
Thank you very much, sir. We might continue. Thank you, sir.
Okay. Unfortunately, I can't play these tapes, but there you go. I don't know what to do, Prof. I tried, but I'm playing it here. You can't hear it. I'm going to summarize now. So, what are the techniques in motivational interviewing? We've talked about what are the techniques, practical techniques. One, open-ended question. Open-ended question, very important. Reflective listening. Affirmation, you affirm what the patient said. Yeah, I can understand. Any positive, you want to affirm it. Summarize what you've heard. So the guy come in, open-ended question, you listen to them, affirm what they're saying. I can, you're empowering them, summarize what they say, and engage in change talk. During the time you're doing these 4 stages or 3 stages they're describing, you're already establishing their goals and you're looking at their behavior. And when you get to eliciting change talk, this is where you bring it together and say, you indicated while you were talking to me that this is your goal, but your B is this. Help me to understand the disparity. The core component is to express empathy, sorry. Make sure you empathize with the patient, where you're coming from, and so on. I know how difficult it is. I can imagine, and so whatever it is that you want to say. Avoid argument. Avoid argument. Roll with the resistance. Develop discrepancy, which is reflective of this chain talk, and support self-efficacy. And essentially, what you want to do is to ensure that you are collaborating with the patient, you are evoking the patient towards change, but you're doing this respecting the patient's autonomy. You're in the driver's seat. I'm going to be working from what you want to get the change that is coming from you rather than me imposing it. That's motivational interviewing. So this is my little slide that suggests it. Of course, we know that motivational interviewing has been applied in so many disease conditions and different. We know the different. I mean, the results. And some references will be in this slide. Substance use, compliance with treatment generally in chronic disorders, engagement in treatment, HIV, risk behavior, diet and exercise, other forms of addictions like gambling, and generally even healthy behaviors. And you do have some references here that from very old references to more newer references. Unfortunately, I couldn't play any of the tapes. I'll see if you could. I don't know. Can you hear this? No? Can you hear it?
Not yet.
No, sorry. I give up. Okay. Thank you very much. That's all I have got to say. I'll send this. Hopefully you find it, and we can talk when we go beyond introduction. Usually when I do motivation interviewing training, we go for about 2 days, but we consolidate sometime to a day. So I look forward to a day that I'll come and do the workshop, or we'll do the workshop and we all can practice. Thank you. Good morning.
Prof, sir.
Thank you very much, Dr. Professor Ahmed, for your beautiful lecture. Thank you.
Thank you, sir.
Luckily, we advertised it a bit early, and a few more people turned up compared to last week's lecture. So thank you very much.
Thank you.
I think that 1 hour is too tight for this. So I'm thinking that whenever you have another hour on a Saturday around this time, if you let us know, we'll be able to create time for especially the video and things that would come up as a result of it. I'm seeing that the motivational interview is core in a way, because it would give everybody another opportunity to learn interviewing techniques, because the same things that we talked about, the attitudes, the requirements of the therapist is going to be required in every other therapeutic endeavor any of the psychotherapists are going to do. So thank you very much.
Thank you, sir.
We are hoping that if we're able to get the videos, and then we'll be able to look at them during the week. And I'm sure that as we discuss over the week in our chat group, maybe more things will be laid bare and questions. So once in a while, when you are free, just check up that chat group. There may be questions lined up for you. And for the doctor who mentioned the patient with pentazocine, the pharmacist, I don't know, if you want, you can contact any of us, the older ones. Maybe we'll be able to give you some information, because some of us have experience in managing such people in our different hospitals. So it's up to you to choose any of the older people, Professor Ahmed, any of the older people that you want to, please do, so that you can get a little more information on it. Apart from that, I think we've taken up to 12 minutes beyond our regular time. So, Dr. Abiola, is there anything else you want to announce? Otherwise, you just tell us we've closed for the day. Thank you.
My apologies, sir. It's just to emphasize that some people have not voted on the poll to mark their attendance. Please, it's essential they do that. Of course, many people put their name. That's very okay too. But the two are needed. I know there are some other teachers who are also here, like Professor Uwakwe. I think I saw him. And then there's one Dr. Isaiah Origi. He said he wants to make a comment. I don't know if that is we can accommodate that within the time frame.
Let's give him a chance because let's let him make his comments.
Dr. Isaiah, please kindly go ahead.
I hope he has unmuted himself. I don't think maybe he has some network
Thank you very
issues.
much, sir. Thank you very much, my.
Kindly unmute yourself.
Is it?
Okay.
The alternative is typing the comments and sharing it in our chat group. We can still take it up from there.
Thank you very much, sir. I think that will be all for today. The discussion, as always, we say continue on the WhatsApp chat page. We are most grateful to Professor AG Ahmed. We know you started this like 2 a.m. or 3 a.m. from your side. We are sorry for sabotaging your sleep. We are most grateful for that. And we're grateful to our teacher and father who has always been with us and ensure that we do it right and did ensure that we continue to do it. Thank you, Professor Idufia, Owedo Idufia. We are most grateful, sir. And to all our other teachers who are here, Professor Richard Wakwe, and every other colleagues that are here, I will say we're most grateful to you all. Across all specialty spectrum, we really appreciate your participation. But like as we said, please, the discussion for this particular important skill continues on the WhatsApp page. Let's endeavor to participate because it's very essential. Without this skill, then we might be losing one of those very core skills needed to start practicing as a psychotherapist. We need this and we cannot be overemphasized. And that's why our teacher father have said that we are pleading for more opportunity, for more investment in this. And we look forward to more things that we'll get from Professor AG Ahmed and from all of us too. Thank you so much. In the absence of any further questions or contribution, I will call on Professor Dufia. Thank you so much, sir.
Professor Dofia had said we should close, that you should give your last words. So I see that those are the last words. I hereby declare this meeting closed.
Thank you, sir.
There you go.
Thank you, everyone.
Bye-bye.
Bye, sir.